So I think Dr. Britton is going to have a more expanded discussion of delirium. But I need to introduce a little bit of it today in order to make dementia more so here we go. The objectives here distinguish between the two, and then we're going to move more into a discussion of dementia, and then we'll talk about dementia-related diseases, how to recognize them, and what to do about them. There's some pharmacology on this sermon today, and this is stuff you need to know. First of all, you can summarize delirium as basically a disorder of attention, a loss of focus. It says it may be easily mistaken for a psychiatric illness because delirium, 99.99% of the time, has a reason for it. And the reason for it would be one or more of all of these. Unlike dementia, where there's a reason for it over considerable time, delirium is an acute process. It says acute or subacute. By that you're meaning hours to days. Hours to days. Somebody shows up in the emergency room, which is where patients with delirium will usually show up. They usually don't show up in your office. They usually show up in the emergency room and are brought there by someone else. Most of the time they're brought by a family member or friend and not IMSA. But on occasion they're brought by IMSA. But most of the time it's like, you know, Kathleen's not acting right. And she's not acting right because of one of these problems. Now the problem with delirium and dementia is it's more like veterinary medicine or pediatrics. You're not going to get a history or an accurate history most of the time from the patient. They're not capable of that. You're going to have to rely on their family member or friend who brought it in to tell you the truth, which when you're dealing with drugs usually doesn't happen. The truth usually does not happen. Cause of the delirium, drug overdose. If you've ever seen a crackhead on a 5-day binge, you'll know what delirium is. They haven't slept in 5 days. They're wired up beyond belief, tachycardic, hypertensive, sweating, dirty. That's delirium. And they have no idea of where their person, place, or time is. That's a good example of delirium. Other things with drug overdoses is, I had a faculty member one time that took an Ambien at his normal bedtime at 10 o'clock, and 10 milligram Ambien, which is an adult dose. He woke up at 1 o'clock to pee. He couldn't remember if he took his Ambien or not, so he took another Ambien. So when he showed up to work the next morning, he was in clinic, and not knowing how he got to work, not remembering how he got to work, or the travel to work. I was upstairs, and the faculty members came up and said, "You need to come down and talk to Roger. I think he's having a stroke." Well, I went down, and he was just goofy. You know, he didn't know where he was. He didn't know what he was doing, and he was in there seeing patients, and no telling what was coming out of his mouth, seeing these patients. The boy had a touch of delirium from Ambien induced. They did a $15 billion workup of him. You know, LP, MRI, MRA, CT, CTA. I mean, they did everything. Turns out it was like, oh, wait a minute, he took one too many Ambien. So, Ambien-induced delirium is what he was diagnosed with. Withdrawal, you know about delirium tremens, with alcohol withdrawal. It also happens with people who stop abruptly anything that essentially crosses the blood-brain barrier, like SSRIs, SNRIs. Chantix, a lot of things that you should be tapering rather than stopping acutely can lead to delirium. What happened here? Where did I get? And poisons. Poisons, there's a whole host of things about poisons. Household poisons versus, well, just anything you can imagine. Endocrine, thyroid and the adrenal glands are probably the two biggest culprits there. Head trauma is self-explanatory. Infectious, it says any, not just the nervous system. And so you have to think about people that are going to, 90% of the people that show up with delirium or dementia are going to be the elderly. It said in the previous slide, the extremes of age, the young and the elderly. So 90% of them are going to be the elderly. One of the things you have to, you'll run into is the nursing homes will transfer a resident to the ER because of altered mentation. You see that all the time, altered mentation. And you have to do a septic workup on them because that's one of the primary causes for this in the elderly. Now, stroke is obviously a cause, but a lot of times you're going to find out what the cause of the delirium is urosepsis, a bladder infection. A simple bladder infection in the elderly can produce cognitive problems like this. Metabolic would mean things like diabetes. Too much or too little sugar can produce this. Seizure and tumor are obvious. Miscellaneous down here, where you've got high fever, and then you have certain medical or surgical issues here. Fractures. One of the biggest things for delirium is hip fractures in the elderly. Up to 50% of elderly people with hip fractures either present or develop delirium as a result of that fracture. Now, what is it from? It could be from, it's not the fracture itself. Most of the time you don't know what it's from, but a large percentage of the time, like 20% of the time, it's going to be from medications. You give them too many narcs and they don't know where they are. You put an 85-year-old with dementia in a new setting like like a hospital, all of a sudden it's a situational thing. They don't know where they are. Okay, so it's dementia with delirium. Lupus cerebritis here is you know about systemic lupus affecting the heart, the lungs, the kidneys. It can also affect the brain as well. So symptoms of delirium. You just cannot keep these people focused. If you try to get a history on them, you're just going to go round and around and around and around and not get anywhere. You need to attempt it, but if you're not getting anywhere, don't waste an hour of your life trying to get a history on somebody that cannot give it to you. Go find somebody or make a phone call to somebody. Make a call back to the nursing home. You sent them over with altered mentation. What was his mentation before you 2 days ago? So that's the kind of help you're going to need. You get all sorts of, the range goes from simple not alert to a place and time to, there's spiders crawling up the wall. I hear, why are so many people talking to me all at once? It just runs the gamut. Anomia is, we've talked about the mental status exam to name 3 objects. What is that? You can't do it. Your focus is not there, or you just, no, I don't know. Agraphia is essentially writing, so the inability to write the language. Acalcula, obviously, is not being able to do math. Retropulsive gait disorder. This is one of the few things that, think about this. You get somebody that is drunk. Like Margaritaville drunk, right? And they're standing there like this, and they're talking to you, and then all of a sudden they're backing up. They're backing up, they're backing up. That's a retropulsive gait disorder, okay? Walking backwards, okay? All right. Diagnosis, so it's a symptom. Now it does have an ICD-10, delirium does have an ICD-10 code for it, so it is a diagnosis, but it's with a cause. You've got to find the cause here. Once you take care of the situation, the cause, it usually, it will resolve. So delirium is a reversible condition. Not only is it acute, not only is it, hours, days in development, it's, once you take care of the cause, it's reversible, it reverses. This is completely unlike dementia. Dementia does not reverse. Let's see, here's one, now I mentioned the elderly person with the urinary tract infection. Here's another one here. You see that when you're working these people up, troponin is in the mix here. When an elderly person comes in with delirium, get a cardiac panel. Get a cardiac panel. You need troponin, CKMB, get a 12-lead EKG, work them up for an MI, because that should be in here as well. These people are really, you're going to see this. You're going to see this every shift in the ER. You'll see an elderly person with delirium. And so they're tough people to deal with, because you have to find the reason. If you can't find it with simple things, then moving on to a higher order of investigation is required. Teenagers, when they show up with delirium, make sure you get a finger stick blood sugar early on. You probably should, in all cases of delirium, finger stick blood sugar should be on here. Don't wait for a CMP to come back. Get a finger stick blood sugar. If the finger stick blood sugar is normal, especially in a teenager or somebody in their early 20s, somebody your age, the cause 9 times out of 10 is going to be drugs. So that urine tox screen is an important thing. You got to convince them to get it. They've got to agree to let you test them for drugs. And so you're going to have to use a little bit of coercion to get them to do that. I don't know, did I ever tell you guys about the little trick I did with the cock-tipped applicator? I had this guy come in one time. Of course, he came in, he was a 16-year-old, 17-year-old, came in with like 10 of his friends, and they were all, oh my gosh, he's dying. Very histrionic, the whole bunch of them. And the guy was histrionic too. I mean, he was just like, he was this lecture. He was, in the ozone, and he was hypertensive, I can't remember what it was, but it was really high. And I said, have you done any drugs? Nope, 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 nope. And then everybody in the room denied that anybody had done any drugs. I said, all right. And I took a cotton-tipped applicator, one of those 6-inch applicators out of the thing, and I put it in his mouth. I said, here, put this in your mouth right here, between your cheek and teeth. Just leave it right there for a minute. Let me ask you some more questions. And I left it there for about 3 or 4 minutes while I was asking him some more questions. Then I pulled it out of his mouth and I said, now you tell me, when I send this down to the lab for drugs, it's going to come back negative? Is that what you're telling me? And he paused for a minute and he said, okay. Well, we've done some phentermine and something. He just spilled his guts on this whole pharmacy of drugs he'd taken already. And so I thought that was a pretty cool little trick. Because if I took that down to the lab and said, would you run this up for drugs, it would come back negative. Because you can't run it. So I didn't really lie to him. So I thought that was kind of a neat trick. So I've used it several times since. I tried to get it published. The reviewer came back and said, this is slick, but it's probably unethical. So it worked. It works only on teenagers. Because they don't know. Okay. Any questions about that? Any questions about, all right. You know, whenever you treat delusional states, though, or confusional, and I'm not sure that word is spelled correctly because it keeps popping up as incorrectly spelled on the computer here, but I tried 50 different variations on confusional last night, and none of them worked. So if you know how to spell confusional, let me know. It's not a word? I'm not sure. It's kind of like the Q-tip trick, you know, it may not be a thing. We have a guest in here, so we have to behave ourselves a little bit today. Okay, so we just make up crap. If we don't know the name of something, we just make it up. This is, so, treat the underlying condition, surgical, and that surgical goes back to like the hip fractures or, you know, some type of, not only hip fractures, but any long bone fractures, particularly the elbow. Thiamine. Thiamine, remember we were talking vitamin B1 with alcoholics. And the reason that is with thiamine in glucose is that if you just give glucose, they wind up in acidosis because of the pathway required to metabolize the glucose without vitamin B1. Vitamin B1 is important for oxidative phosphorylation. If you go back to that, you know, the biochemistry and stuff. So that's why you give vitamin B1 to prevent acidosis. You can give it IV or IM, it doesn't matter. If you give it IV, it's just a slow push. So you just stick it into the IV line and over, you know, 30, 45 seconds, you just let it run in, right? A slow push. Use sedation only after you've determined what the cause is. And this is a maxim you need to understand. If you have somebody that's delirious and you put them to sleep, then you've lost the only diagnostic tool you have, and that's the patient. That's why you don't put them to sleep. If they're getting worse, you need to know about it. If you do something to them, if you give a thiamine and an IV of dextrose and they perk up, you need to know that. So if you zonk them out with narcotics, then you lose that. The same is true for anybody presenting with either to the ER or to the clinic with abdominal pain. You never give somebody with abdominal pain analgesics unless you have the answer. If I know that your abdominal pain is due to an ovarian cyst or endometriosis, that's fine. But if you come in presenting with lower abdominal pain and I mask it with a narcotic and you turn out to have appendicitis or mesenteric ischemia, then you might as well call a lawyer. So those two instances don't mask with a narcotic, delirium or abdominal pain, particularly in a woman. Okay? I should say female, because a woman is generally considered above 18, and so, yeah, okay, you know what I mean. Any questions on delirium? All right, so let's move into dementia here. Dementia, whereas delirium occurs in hours to days, dementia occurs over months to years. And it's progressive, it will not reverse, it will not get better, it will only get worse. It says here dementia is not a clinical diagnosis. It is an ICD-10, it does have an ICD code, ICD-10 code. However, there is a reason for dementia, just like there's a reason for delirium. I mean, the most perfect example you know is Alzheimer's. So there is your ICD-10 code can beat dementia, but you have a second diagnosis of Alzheimer's. Because there are stages of Alzheimer's that really aren't dementia yet. Okay. All right. The differential diagnosis depends on how they present, and there's subtle differences between some of these dementia diseases we'll see as we go along. Now, dementia is related to cognition. Plain and simple. Dementia is you are disconnected from the cognitive world. So what is cognition? Cognition is you answer those 6 things, that's cognition. And I sat there and looked at these 6 things and I tried to come up with, okay, what one word would use to describe cognition? Well, it's awareness of everything around you. Well, that's up there. It's comprehension of everything around you. Well, that's up there. It's knowledge or understanding. It's all up there. All of those things together form cognition. And so, if you stop and think about it, everything you are related to these is based on memories. It's based on your perception and your memory of that. So if we go back and remember the different types of memories, the top one there, the declarative memories, just facts, pure facts. That's going to involve the hippocampal formation because we know that the hippocampus is responsible for taking short-term memories and putting them into long-term memories. And those things that are put there are facts. Plain and simple, they're facts. Now, if you look at the other types of memories here, these are all non-declarative memories. The motor memory here, the one in the middle here, is riding a bike, swimming, doing something without having to think of walking, talking. Talking is you don't have to learn how to talk every time. Now, if you have an insult to your nervous system, you will have to relearn how to walk. That's what speech therapists are for. Okay, but to do that, it involves the motor components: basal ganglia, cerebellum, and precentral gyrus, frontal lobes. Okay, motor cortex. Interoceptive, emotional type of memories. This is the amygdala, the limbic system, which includes the posterior insula, and the neocortex. The neocortex, remember that the amygdala, this emotional part of your brain, is the most primitive part, right? That's the 3-layered cortex. But it involves the 6-layered cortex, the neocortex, because how you respond to them. How you respond to it. Remember, I gave an example. I think I gave an example of, if Kathleen's sitting here and I handed her a rose, then her memories of what a rose is always associated with good things, so those are your memories from an emotional standpoint. And then finally down here, executive memory, metacognition is essentially your projection into space-time, insight, foresight, that type of thing, morals. This is all prefrontal cortex. So dementia is the development of dementia is related in part to what aspects of the central nervous system are lost. In Alzheimer's disease, you're losing the ability to form memories. So you're going to lose the hippocampus, the neocortex here. We'll just leave it at that right now, okay? If you lose the occipital lobes, that does not equal dementia. You have to lose the parts of the nervous system that are associated with creation of memories and cognition, okay? Now, speaking of cognition again, how do you measure that? Well, there's a thing here called a cognostat. And if you downloaded this before last night, you got the old version. So I put this in here last night. A cognostat is a test that I ask you questions over about 30 minutes or so. I ask you a series of questions. It's kind of like the mini mental status exam, but it's more geared towards cognition. You know the mini mental status exam where we're looking at recall, orientation, language, well, that's all in here. But also your awareness of your environment is in here as well. So a cognostat is a test that you administer in the office. Just takes you a few minutes. You get this is a billable thing, by the way. And then what you get is you plot the patient out on their overall cognition along these several different lines here: calculation, construction, memory, language, attention, all of these things. And so if Grandma, you take Grandma to her primary care office, no, not you being Grandma, you take your Grandma to, actually you go to your Grandma's, it happens very fast. So, anybody in here a grandparent? Nobody in here is a grandparent that you know of?
But you have to have kids to be a grandparent, yeah?
Do what?
So don't you have to have kids to be a grandparent?
Well, yeah, there are several kids in here. There's several kids in here. They're just little. Okay. What were we talking about? Okay. So you take Granny to see her PA every year for her annual visit, or checkup. But every year, Granny seems to be losing a little bit of an edge. Well, the purpose of a cognostat is not a point in time, it's a point in time over time. So I can see over time where your cognostat, I can see the decline in your abilities as you, over time. Okay?
Do you only start doing this when they start showing, like if they're failing with just signs of dementia or something, or is this like a certain age you start?
No. You can use your just judgment here. If somebody has a complaint that Granny's losing her car keys, or it seems like every month for the last 3 months, Granny will call me. She'll have gotten in her car and gone somewhere, but can't remember now how to get back to her house, or she can't seem to recall events, like what she had for breakfast that morning. Yes. It doesn't hurt to get a baseline on anybody over, well, again, you have to use your judgment, because not everybody's the same. You may have an 88-year-old, my dad's 83. He lives in a condo, he lives by himself, takes care of his own affairs, doing well, still drives. I'm not going to mess with a cognostat on him versus somebody else who is obviously has issues. So you're just going to have to use your best judgment. And if you have a question, if you see a patient and you have a question after interviewing them, get a cognostat. Okay? And there are 50 billion other tools that can be used to assess the same thing. Which one you decide to use is going to be up to you. Okay, dementia by the DSM-5. You guys know what the DSM is? Manual of Diagnostic and Statistical whatever something or another. It's produced by the American Medical Association. We're up to 5 now, and it lists, when you say ICD-10, they're the ones that's where it comes from. Okay, so if you look at the, I'm sorry, that's not the DSM, that's the ICD-10 booklet. The DSM is put out by the American Psychiatric Association. The American Psychiatric Association defines every mental illness. That's what the DSM is. Diagnostic and Statistical Manual, I think is what it's called. And, is that right? Yeah. And then, so if you look up dementia, in order to make the call on dementia, these are the criteria here, okay? So memory loss. Memory loss as determined by a cognizant. One or more cognitive impairments determined by a cognizant. Functional impairments in IADLs. ADLs are activities of daily living, like bowel and bladder function, toileting, eating, getting dressed. Those are activities of ADLs. IADLs are more significant. These are the instrumental activities of daily living. These are what allows you to be independent, to live independently, that you can take care of your financial affairs. You can provide for your own mobility. You can get to the grocery store. Okay? So functional impairment in the IADLs is part of dementia, and of course, you haven't screwed up and missed delirium. Now, these are some of the IADLs. Here are the ADLs down here, and these are the IADLs. Now, this scale here, the Lawton scale, it's just 0, 1, or 2. If you do it, if you can't do it, if you do it somewhat but not well, you get a 0, 1, or 2, or however I said it. And you come up with a number. So normally, the highest here you can get is 16. The lowest you can get is 0. There's not a cutoff between good and bad here. It's a scale. If Granny this year is a 16, next year she's a 14, the year after that she's a 9, then you're documenting that decline. And you need to have a reason for it. Okay? All right. Causes of dementia, cognitive aging. As you get old, you just lose your edge. You do. You just lose your edge. Sometimes I forget things. I'm 60 years old. Sometimes I forget things. And my wife, she gets irritated. And I just really don't give a shit. It's a lot of old timers. We just don't care. Don't care. I've got other things to deal with, So, with atherosclerosis, the progression of atherosclerosis, and just the aging nervous system, there is just a natural aging of the CNS. Whether you don't care or you're just, you hear about the cantankerous geezer, that's what I'm becoming rapidly. So it's just a normal part of aging versus a pathological part of aging. That's what you have to distinguish. A lot of people bring their grandparents in or great-grandparents in that they're not acting right. Well, they're not acting right because they just don't care, or for something like that. They don't have dementia. They just have other priorities. And that's something you have to distinguish. Now, and included in that are some things that might appear as dementia. You can't multitask anymore. Sometimes words fail you. Finding the right words fail you. A little bit of forgetfulness.
Pardon me.
That's the normal part of aging. Now, one thing you've got to watch out for, especially in this group, are these down here. That you're not inducing it with medications. Most of the time, young people your age have one problem that's usually treated by one drug. When you get older, you have multiple problems treated by multiple drugs. Polypharmacy, has Dr. Latassi discussed that with you yet? You know, when you get somebody, when her granny comes, she brings her granny in because she seems to be losing her cognitive edge, and she's on 15 different medications. Why is she on 15 different medications? Because she sees a pulmonologist, cardiologist, urologist, family medicine doc. She sees all these docs that everything is treated with a pill. And they get added up, and nobody looks at what the other pills work. Then you've got somebody on a beta blocker for headache, and then an ACE inhibitor for her hypertension, and blah, 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 blah. Okay? So when you have somebody that's appearing in this region here, age-related changes or dementia, you need to go over the drug list. If they don't need it, get them off of it. Okay? Now, causes of dementia, there are several causes. One of them you've already had is multiple sclerosis. Hydrocephalus, I believe we talked about hydrocephalus in terms of normal pressure hydrocephalus. You know, the key here in normal pressure hydrocephalus is very common in the elderly. It's an elderly person disorder. Incontinence is the thing. That Granny has never had a problem with incontinence, and now she does. Incontinence doesn't mean leaking. You know, like if you're a female and you cough and you dribble on yourself, that's a normal part of aging, really. Incontinence means pee on yourself, you know, a full-blown urination. That's not appropriately timed. So the other thing about normal pressure hydrocephalus is outburst of not appropriate laughter or crying is more, crying is becoming quite tearful. Okay. Masses, that's obvious. Infections. Infections, there's a whole list here. In the young people, we're talking about HIV encephalopathy or PML right here. PML is an opportunistic infection in people with AIDS. It's due to a viral infection in your body's reaction to it. Very bad disorder. Toxoplasmosis is the issue with cats. That's why you should eliminate all cats in the world. I've seen dementia in my career. I've seen dementia related to Creutzfeldt-Jakob disease, the prion disease. I've seen it related to HIV encephalopathy and PML. So I have not seen tubercular or toxo dementia, but it's out there. Metabolic, all sorts of things here are related to it, and vascular is self-explanatory. Okay. You have a question? No?
No, I'm just itching my.
Oh, just itching.
So with the drugs, is that like they're causing damage over time that leads to dementia?
Drugs, you mean in terms of these things here?
Mm-hmm.
No, not that it leads to damage. Mm-hmm. It leads to impaired neural function.
But
you
is
take
it
away
permanent?
the drugs, you take away the drugs. This is not let me see how I want to express this. If I say if you take away the drugs, you'll get better, then that, by definition, is not dementia. But that is, in fact, what happens. You have a person who is having trouble with their IADLs. And then you look at their polypharmacy, and if you can get rid of some things, you may improve the IADLs. So, in a sense, it does reverse dementia. Okay. This is more, though, dementia related to the normal process of aging. This is not the Alzheimer's slide. Okay? If I have trouble writing checks and paying bills now because I can't stay focused, right, or I'm just forgetting, did I pay that bill? Then get me off of some of the drugs and that may improve. I've seen people, my dad takes 10 pills in the morning, every day, 10 pills, 10 different drugs in the morning, and then like 8 in the evening, you know? And that's, each of those drugs actually has a function. You get somebody that's not aware of pharmacy though, and I've seen that number 20, 30 different drugs. It's crazy. Okay. Okay, so go back to this. Okay, okay, so here we go. Here's what we want to talk about a little bit here more. Degenerative causes of disease. Pick's disease is a type of unknown degeneration, particularly of the frontal lobes and the temporal lobes. Very rare. Spinocerebellar degeneration involves again, the motor tracts. Let's focus our attention on Alzheimer's and on Lewy body dementia. Okay. First of all, Alzheimer's. Alzheimer's. Here are some bad statistics. 10% of Americans over 65 have Alzheimer's. So 10%. So that means about over 5 million Americans only. It's the sixth leading cause of death. And I want to explain that, is when we go through the symptoms or the progression of Alzheimer's, how do you die from Alzheimer's? How do you die? It's not like you had a heart attack. It's not like you had an infection. How do you die from neural degeneration? It doesn't affect your respiratory center or your cardiac center, so how do you die? Well, I want to say that for just a minute, because for many years, I thought nobody dies of old age. Nobody dies of old age. You died of a stroke, or you died of an MI, or you died of an infection, but nobody dies of old age. But I know now you do. And that's what I want to explain when we get to that slide. And that's why it's the sixth leading cause of death. Okay? 1 in 3 seniors. That's startling. This is also startling. Heart disease has decreased, death due to it, has decreased over the past couple of decades, but look what's happened to Alzheimer's disease. That's just nuts. And this is probably a gross underestimate right here. Managing an Alzheimer's patient is expensive. It is very expensive. Okay, so I found this last night when I was Googling around, and I liked it so much I copied it. So this first sentence is very correct. Every person with Alzheimer's disease experiences the disease differently. Patients tend to experience a similar trajectory, and there are 7 stages of Alzheimer's disease. So the trajectory, for Taylor, it may take 10 years. For Kathleen, it may take 2 years. So the trajectory is different. From the beginning of the illness to its merciful end. Merciful end. That's a pretty brutal statement here. Don't you think? To its merciful end. Thank God they died. Right? So I knew this guy. When I moved to Oklahoma, I rented a house from this guy. He was 60-something years old at the time. I rented a house from him. And years later, have I ever told you about Don? Never told you about Don? So years later, I rented from him for a few years, then I moved away to another part of town, and then I wanted to move back into that neighborhood, and he owned a lot of houses over in Edgemere. So I called him up and said, Don, do you have any houses to rent? And Don was, he'd never been married, no kids. He has one niece that lives in Washington State. That's his only relative. And Don was just he was a really nice guy. You know, he played racquetball a lot. He played golf a lot with his senior people. And I thought myself a pretty good racquetball player. So one Friday night, I wasn't doing anything. I called him up and said, Don, you want to go play racquetball? He said, well, I had surgery on my shoulder. I was going to wait 2 months, and it's only been 6 weeks. But yeah, I'll go with you. I go pick him up. He's got Bermuda shorts on and a shirt like this to go play racquetball. And I'm dressed up with my little, you know, ready to, you know, athletic stuff, you know. And I'm thinking, oh man, this is going to be bad. You know, so I take him up to the club, and, you know, rather embarrassed about this guy. Looks like he's on a cruise ship for seniors and stuff. He beat the shit out of me. I mean, he just stood in the middle of that. Anybody here play racquetball? It's a tough sport. I mean, he just like stood in the middle and was doing like this, and I was running all over the place, and I was having palpitations and shit. I mean, the guy was just crazy. So, I mean, he was a really nice guy. And he apologized for, you know, beating the hell out of him. Never broke a sweat. He never had to break a sweat. He was that good. So anyway, I called him up and said, Don, you got any places to rent? I need to move back over there. He said, well, I'm selling all my properties. I'm not. I said, well, you know, I don't even have money for a down payment. He said, well, come over and take a look at this house. Well, I go over there. I wound up on a handshake buying this house from him that night. He financed it. You know, he said, I'll take care of it. I said, Don, you know, I don't have the $2,000 you want for down payment. He said, well, just pay me an extra $100 over the next couple of years, and we'll call it good. I mean, that's the kind of guy he was. Right?
Wow.
So, turns out I wind up, and so decades later, I wind up as the trustee for his estate there. He has Alzheimer's disease, and his mother died of Alzheimer's disease. His sister died of multiple sclerosis. But he got to, he went through all of these 7 stages. I went through all of these 7 stages with him. So that, I think I can speak with some authority here, because it took over 10 years before he met his merciful end. And I would agree with that. Okay. So stage 1 is, you know, there may be some mild stuff, but not really anything to speak of. You know, you're probably, if you're just interacting with somebody, you're probably not going to pick up on it. If you live with them or you deal with them day to day, you probably will. But one visit to your office once a year, you're probably not going to pick up on it. Stage 2, you're starting to lose things around the house, although not to the point where it can be easily distinguished from normal age-related memory loss, the previous slide, right? If you do cognostats on Don early on, showed he was pretty sharp. There wasn't really much in the way of decline, but they progressed pretty quickly over a few years. 3, it starts to get worse. You have trouble finding and remembering things, especially new acquaintances. It got to the point, so Don's goal was to die in his house, and that was the house he was born in, where his parents moved into. They built in 1927. The guy had lived there since 1927. He died in 2016, just to let you know. He died in 2016. But he lived in that house since 1927. Amazing. So it got to the point where I had to get him nurses. You know, the first nurse I got him, her name was Cindy. And then as his disease progressed through other stages, he could not remember the names of the 6 other nurses that I wound up hiring to provide around-the-clock care. Every nurse was named Cindy. Even Mark, who was 6'8", weighs 300 pounds, was Cindy. Okay? Amber Hicks over there, she was one of the he didn't need a nurse. He needed somebody to sit with him because of some of the things you're going to see in a minute. He needed somebody to be with him. He didn't need a nurse. Physically, he was in great shape. But Amber was Cindy. So, I mean, everybody was Cindy. The only person he knew as this disease progressed was me. I was the only one he could recall my name. Everybody else, he lost. Everybody else, he lost. Okay? So stage 4, may forget details about their life history. You know, we had all the stuff from his adult life or his entire life was in that house. So, you know, you would talk to him about his Navy service in 1946. And, you know, it's just amazing what he could recall and what he, you know, I don't remember being in the Navy. You know, it was just impressive. Then you get into stage 5 and difficulty dressing appropriately. And so now he's going to require, and then toiletry, you know, he needs help with day-to-day activities. He could no longer make his meals, obviously. He had to have help going to the bathroom because wiping and toiletry just wasn't there anymore. And then he got into stage 6 here. Wandering is part of stage 6. Funniest thing in the world happened with Amber Hicks. His house was over on 31st Street in Edgemere, right? So Don would walk out the door. I mean, you know, at 2 o'clock in the morning. Insomnia is a big thing here. Somewhere in there it's going to say they lose their circadian rhythms. Insomnia is a huge problem. And Don would get up at 2 o'clock in the morning and go walk out the front door. And the neighbor, early on before I got all of these nurses there, the neighbors, they all knew my number. They would call me and say, you know, found Don down the street. And, you know, you see these silver alerts. That's why. These people don't know that. They don't know. They are not aware that they've left, that this is not the right thing. They're completely clueless about that. So we started putting all these kind of locks and alarms on the doors. It was pretty impressive, the degree to which we had this house secured. So to keep him from wandering. Well, one night, you got to ask Amber about this, because she did overnight, like from Friday at 7 p.m. to Saturday at 7 p.m. or something like that. One night, he goes out the door, and she had fallen asleep on the couch. He goes out the door, and she suddenly wakes up and sees the door open, so she knows he's taken off. So she goes running outside. He's in the front yard. So she goes and gets him to try to get him back in the house, and all of a sudden he starts screaming at the top of his lungs about this woman who's kidnapping him, and just total, nothing about this is right, and help, help, and the neighbors' lights are coming on, and this person is outside, and Amber's trying, you know, okay with the neighbors, you know, it's okay, so you have to ask her about that. It's pretty funny. She called me quickly after that and said, you know, when you get calls from the neighbors, this is what happened. Okay, so how do you die of Alzheimer's disease? That's right here in number 7. I think patients lose the ability to respond to their environment or communicate. They have no insight into that, how bad off they are. They stop drinking. They stop drinking and they stop eating. They just stop. I don't know why they stop. They've just determined that this is the end. They just stop. And that's what happened to Don. Amber was on when he decided to stop. I don't know if it was something he consciously did. I don't think he did consciously decide to stop. But she couldn't get him to eat breakfast, and she called me, and he won't eat breakfast. And I said, well, just try it again here in a half an hour. And no, he did not eat anything. And then she called me back, he's not drinking anything. He hasn't peed all morning long. And so this was on a Sunday. We had switched days or something. This was on a Sunday. The following Thursday, so you're talking what, 11 days or so, he died. And it was basic. Bottom line is, he just quit. He quit living. And so when you look at how you die with Alzheimer's disease, it's not an MI, it's not a stroke, it's not an infection. It's just you lose the will to live. You quit eating, quit drinking, and he died. Any questions about that?
Yeah, when he was my
You're gonna see that a lot, and you're gonna want to do something about it, but you can't. So the first Friday, so he quit eating on Sunday. The first Friday, my wife was one of the caretakers. She was convinced he had a UTI, and that was the cause of his dementia. No, it was his Alzheimer's. He was in stage 7. So she would not let him go. So she made me bring a liter of fluids home and run a liter of fluids in him. Because she knew that all you got to do is rehydrate him so his kidneys start working, he'll get better. No, he won't. He's going to die. So while it took him 11 days to die, I'm certain that if I had not run that liter of fluid, he would have probably died that weekend. But still, you can't fix it. You've got to let them go.
When he was playing racquetball, was that with his bad shoulder or his good shoulder? Like, did he
That's
beat you with one
totally
arm?
irrelevant to this conversation, so I'm not even going to answer that. I'm talking about death here. And so you're going to run into this. You're going to run into it with your own family members. We've been telling you that you need to talk about a advanced directive and things like that. This is why. Okay? Anyway.
Did you let him die in his house?
What's that?
Did you let him die in his house?
Yes.
Oh, that's
Yeah. Yeah, he did. Unfortunately, he died on Mark's watch. And Mark had no medical experience. So he was pretty torn up about this. But it's like, no, it was his time. He was 89 years old. That was it. Okay? Do you need to take a break?
Yes.
You take a break? Okay, go take a break. So this, before you take a break though, this slide right, all this slide does here is summarize it. This summarizes it, so I won't go over that, okay? All right, take a break.